Jim Mark held a lot of leadership roles, including president of the American College of Chest Physicians. He was one of the early innovators and adopters of video thoracoscopic technology. And many years ago, he and his family endowed this lectureship, and we were indebted to the Mark family. This year, we have the distinct honor of welcoming Dr. Yolonda Colson as the Mark Visiting Professor. I really like that photo.
My admin assistant.
Yeah, that's the AATS photo. Dr. Schrager will say a few more words about Dr. Colson, but I just want to say that I think what's most important is you epitomize the surgeon scientist. You have been an NIH-funded researcher for so many years and have made so many innovations in thoracic surgery, basic science, and in translational care. Dr. Colson was on faculty at the Brigham, a world-renowned thoracic surgery program, arguably the greatest at that time.
I have a hard time seeing they're still in the NGH act.
And then went on to become the leader, the head at the NGH, who some others would say was a remarkable program, but now is absolutely a top-notch program. And in one particular capacity that we have linkage is Dr. Colson, as Division Chief, has been an amazing mentor, faculty supporter, and has nurtured a young faculty member to become likewise an NIH R1 funded surgeon scientist. And that person is none other than our own Jeff Yang. So we thank you for taking Jeff to the home running level. And I think perhaps most importantly, Dr. Colson became the president of the AATS. And in that capacity, led the AATS through some rather tumultuous times in changing the structure of the entire organization, and also dealing with challenges related to COVID, challenges related to other major societies, and in her tenure as president, really took the AATS to a new level. I want to yield the floor to Joe Schrager, but I do want to say a couple words, and that is that Joe has really built the Stanford Thoracic Division to an incredible level. Started with just 3 surgeons and a very small volume, and now has become one of the real pioneering programs in the country. Every single resident in general surgery wants to come here to train in general thoracic surgery. And I'd like to think it's because of the great cardiac surgery that they learned, but I think it's probably the thoracic surgery that they learned. And really that comes a lot from just the amazing, patient, skilled teaching faculty that we have. And really grow that division under Joe's leadership. And I see many new and exciting opportunities in the times ahead. So Joe, please come up and introduce our speaker.
To shorten my comments, we'll leave for Dr. Colson.
So it's my great pleasure to introduce Yolanda. Yolanda is an engineer and scientist, as you've heard. She actually has a BS in biomedical engineering from Rensselaer, which is a hardcore engineering school on the East Coast that you may not have heard about. And then PhD at the time when it wasn't that common for you to get a PhD. She did her general surgery at Pittsburgh and thoracic at the Brigham, where she quickly rose afterwards to assistant associate professor ranks. So for 4 years, she's been the division chief at MGH, and the Hermes Grillo Professor of Surgery. She, of course, just completed her year of president of the AATS, the first and only woman president of the AATS. And probably one of her most important accomplishments, I'm sure she would say, is mentoring all residents, junior faculty, but in particular women, junior faculty, many of whom really have benefited from her mentorship. She's also president of the Women in Thoracic Surgery group. Now, Hermes Grillo, the namesake of your professorship, was my mentor. And from where I stand, to be the Hermes Grillo professor is truly the ultimate compliment. He was amazing, basically inventing tracheal surgery from scratch. Figured out the problem of tracheal stenosis related to intubation, designed the problem, had the guts to start operating on cartilage, which like Tahina, essentially. And, he was just a model of a wonderful teacher, a wonderful person, epitomized attention to detail in surgery and care of the patients. So I'm sure Yolanda appreciates that compliment of this Grillo professor. Interestingly, though, you're a Brigham person historically, and if anybody knows anything about Boston politics, to think that somebody from the Brigham would become the Grillo Professor of Surgery would have been blasphemy until very recently. So I'm sure that Keith Willemo, who's the chair of surgery at MGH, saw something coming and saw that you would be sort of the vanguard of bringing Mass General and Brigham together. And we now have Mass General Brigham, obviously the ads on TV, like essentially unifying the hospital system. Joe mentioned she's really one of the models for the residents of how to pick a field of research, translational research that's directly relevant to the work, and to just stick with it through thick and thin through the whole career, and patents and innovations and really amazing stuff. So I'm sure that's what she's going to tell us. So, you're welcome.
Hopefully the update didn't do anything. So I can't tell you how exciting it is to be here. We were talking a little bit at dinner, and I hope to tell more. I actually came here, I had one rotation as a medical student, and I chose cardiac surgery at Stanford for that rotation. And it was a very thoughtful decision, and it completely changed my life. There's many people in that division and department that I owe a lot to, so it was quite an honor to come back. And I've been emailing back and forth with Dr. Mark, and it's been quite a great discussion we've had back and forth. As he said the other day, we're becoming pen pals. I was like, that's great. So it is in his honor, and it is in a great honor to talk to all of you and to tell you a little bit about what we're doing. And I think talking about the role of what the surgeon scientist does, because you really have to listen to both parts of that phrase. You have to be a surgeon, don't forget your day job, and you have to be a scientist. It makes you a better surgeon. And if you can look at it in that way, you will be well suited. So I think I'm very honored and thank both of you for the kind words. And I don't think any of us quite saw the end to be in the same way coming. And it's been an honor for me every day to go to work and with the group that I have at MGH. I cannot think of a better, more important, dedicated group that I've ever worked with. So this is great. Disclosures, I really have no equity or ownership, stock interest. I will talk a little bit about using a camera, a near-infrared camera. You'll see an example that I have an equipment loan, and then I do have a sponsored research agreement with Canon. You can see on the left-hand side the grants that we currently have that we are going to work talking about, that this work came from, and then a number of different residents. I think it's important. We talked a little bit this morning about leveraging all these different organizations for your lab, and I think it's important. So, Dr. Mark, you can see some of the accomplishments, but I thought if you don't know a little, I will talk a little bit about what I was able to kind of glean from his career. He came from Nashville, Tennessee, and went to Vanderbilt, and then did his general and CT surgery residencies at Yale, and then did 2 years as a U.S. Public Health Service in Chicago, which I think is always important for people to do something else that makes you different than you are, learn something different. His cousin actually set him up on a blind date with her neighbor, which is how I heard in an interview that he did. He met his wife, Maxie, and they went on to have 5 children. And the other thing that I think is interesting about him in doing something, taking those opportunities and looking for for things to learn is that he actually was a senior Fulbright Peace Fellow in Tanzania, and I had not known that previously. He stayed at Yale for his first 5 years as faculty, and then was recruited to Stanford by Dr. Chase, which was a really important time in the department's history and its formation. So he became the department chair at Santa Clara Valley, but then was the founding head of the Division of Thoracic Surgery in 1972 and became the Johnson & Johnson Endowed Professor in 1978. He was the associate dean twice, which there's got to be a story. I didn't ask him about it yet. And then became the Department of Surgery chair and then chief of staff at Stanford. So clearly a great person. This is endowed for, and I think is important. And one of the conversations we had, we were talking about influences in your life and how that is. And I think one of the things that I told him is I do really believe that what we become depends on what we teach each other, especially at the times when we don't think we are teaching. Your day-to-day, we have interactions with people. This is the picture when I became president of the AATS. It's our dinner afterwards. And you can see me, obviously, sitting in the front row. But two important people are in this picture, and they are who I was a medical student in their service when I was here, right when I was in Palmstein's. Influential. It was a really important dinner. Multiple people in this, I know. But pay attention to who you're with, even with medical students. They will change your life. So the secret of success in life is really to be ready when your opportunity comes, because you don't know what it's going to look like. Don't get so focused you don't see if there's a different path. So you could argue, what was my path to success? I had this all planned out. Well, you have to realize, I grew up on a farm in an unaccredited high school. Cardiothoracic surgery and the Grillo Professor were not on that path, okay? But there are things that you learn from where you are. You have to work hard, and hard work applies to everyone. On a farm, everybody works. Nobody's sitting inside not doing something. So in order for it to be successful, you have to do it, and you can do anything if you work hard enough. You have to persevere. Some things take a while to happen. Crops don't grow overnight, but also you can get wiped out by a storm. And so some things you have to just figure out. If something breaks and you're in the back 40, nobody's coming to fix it for you. You have to figure it out. And love, respect, and gift of a good community, everybody plays a role, but you have to have a home you belong to, even if you fail, and that you can come back to. So you can argue farm life isn't a really great academic pathway. It's a really good pathway. And you need people who keep you honest, which is my brother. So my brother found this cartoon, I do not know where, and it actually says, "I love you, Yolanda," on it. And it says, no, I wouldn't exactly say it's a sign of higher intelligence. So you need people who keep you grounded. So how do you recognize your opportunity? And here you can see this cartoon, or this picture says, it only looks like a tragedy from where you're sitting. Look for your opportunity. Barrier or an opportunity? So when I started, during my general surgery residency, women were less than 5% of all surgery residents and 0.2% of all CT surgery residents. About 60 of the 5,000 ABTS certified CT surgeons were women, and that's when I came to Stanford. There was no question. I did what I did. I was on the service. No one ever questioned it. I didn't question it. If I had waited for the opportunity to where a third of CT residents were women in 2022, I was too old to get in the program. I would have missed my opportunity. And so you can see the increasing number of diplomats that have been certified each year. And you can see that now there's about 400 women, and now 16%, almost 20% of all U.S. cardiothoracic surgeons are women. It's not to talk about women, it's to talk about an opportunity to do what you like and figure out how to do what you like. You don't think, oh, there's a barrier, nobody does it, it's not possible. Do what you want to do. So don't overthink it. Figure out what your passion is and do that. So for me, it was lung cancer. I really wanted to learn about and treat and take care of patients with lung cancer. It's the #1 killer in cancer deaths. 1.5 million people worldwide, and in fact, it's more women die of lung cancer than breast, ovarian, and uterine cancers combined. It's more than prostate and colorectal in men. But what's important is nodal disease has the biggest impact in surgically treated lung cancer, and it's different in women. 20% of women who have lung cancer never smoke. It's different histologies. We're seeing different types of the way it presents, and they have a higher incidence of tumor-specific gene mutations and better survival. So understanding the opportunity, seeing where it is where we started to look at. And here you can see the increasing incidence of adenocarcinoma, not so much squamous, but men it has decreased, women it has not. And if you look at the incidence of non-smoking women who are diagnosed with adenocarcinoma, it's somewhere between 1.5 to 3 times the incidence of that in non-smoking men and who do not have well. So I want to look at kind of thinking about lung cancer. We have made huge strides in the last year to a year and a half. It is a revolution in what we are seeing. But we're just slowly increasing to about 20% 5-year survival. That will drastically change for some reasons that I'm going to show you. But what I think is important as surgeons, why doesn't surgery with intent to cure always result in cure? And look at these answers and we can address them. 1, we remove it too late. 2, we leave disease behind. And the 3rd is we let it comes back. Not very rocket science, just sit down with a piece of paper in your lab and figure out what are the genes. So this is my daughter. You'll see lots of pictures of my daughter. How can we find and remove lung cancer earlier? So this is a recent paper that just came out actually looking when they didn't do lung cancer screening and when they did. And what you see is lung cancer screening is how we find it earlier. And we're seeing a major shift in the stage of lung cancer when we find it. It's almost doubled the amount of stage 1 disease, so over half of the cancers being diagnosed now are lung cancer stage 1, and it used to be less than 20%. It used to be 13 even before this study. So, and we're seeing an increase in overall survival. So finding it sooner is going to have a huge impact on us, and that is important because that's where surgeons live, is in that early stage disease. What's important, though, is through lung cancer screening, non-smokers don't qualify. There's about 30,000 people a year that are missed by this approach. And that you think about that, that's like ovarian cancer. I mean, it's like a real population. It's not, oh, it's this small group. It's like a whole disease into itself. The problem of lung cancer screening, however, we are going to have to deal with. We currently screen only about 10% of eligible patients in that country. Massachusetts is somewhere around 13, 14, so we're a little higher. But now we're finding all these small nodules and ground glass opacities that are probably lung cancers. And so we're having large numbers of patients that we're having to follow, and we need to think about it as a healthcare system, how we're going to do that. But on some of these small ones that we know are cancers, we now have to figure out how we resect the small non-palpable nodules and ground glass opacities. So this becomes an area of research for surgeons. So here in the past, we would only find small early disease was about 16%. Now we're up to 50%. But what we're seeing is more of these ground glass, part solid, you can see up here in that lower left hand at the corner there, the right side of the patient, left side of the picture. And we're getting these pure ground glass opacities that you can barely see. And they tend to be in groups. Women, particularly non-smokers, often have multiple. They don't qualify for CT screening, but these are all cancers. And so recognizing them and figuring out how to deal with them is going to be a major challenge for surgeons. We're probably going to have to work on AI. We're going to look at a number of different things in order to help us do that. This is artwork by my daughter, my oldest one. So can we learn to see these invisible ones that we can't see in the lab? So one way that's been around for a while, and that we do a lot at MGH, is actually having fiducials placed by it with resections guided by where the fiducial is, so that we can find out what these are. We can then analyze them and take out these much smaller ground glass that you can't really palpate. And that's been very efficient and very helpful to us. The other has been people showing you can use indocyanine green as a way to go down the bronchoscope, navigate down there, and put green dye at the side of the lung lesion with a way that you can identify it. The challenge being we don't quite know what the depth is, and so that's been the advantage with the fiducials. I'm going to come back to this because there's a second part of this study that we found out. So we know that surgical treatment of lung cancer, if you have a complete resection, is how you get your best survival. And we've talked about wedges and segments and lobectomies and pneumonectomies. Lobectomy has been the standard of care, but that's been changing in the last year on these stage 1s. We've started now to think more about segments and wedges. Poor lung function has prevented lobectomies in the past, and so that was the reason and rationale for doing sublobar resections, but we are going to learn that over the next few years, really where that sits. If you do a wedge resection and you have a large tumor, however, then you do have an increase in local recurrence by almost 2 to 3 times. So in our lab, we talked about the idea of how do we push lung cancer screening in order to find things earlier, but then how do we make sure we don't leave disease behind or treat it? And that's really where we started to look at. Can we decrease recurrence by treating disease unknowingly left behind? Okay, we'll talk about where they are. So this is Mark Reinstuff. He is a polymer chemist that's at Boston University. We met at a dinner through a student, and we set off on this quest to do local delivery of drugs and biologics for treatment of cancers and preventing recurrence. Completely serendipitous meeting. I've been with him, we've done research now for almost a decade and a half. Many of those RO1 grants come from him, and we can talk a little bit about the logistics of how you create that partnership. So one of the ideas that came out of this dinner was this idea of how do we prevent, how could we deliver some way to prevent recurrence locally, those few cells that are there, the microscopic things. And we came up with this idea of drug-eluting polymer films. And the films essentially have a drug-eluting polymer with a base polymer, which you can regulate, and then a pericardium or scaffold that's in place. And we had to make it minimally invasive. It had to be strong and a flexible platform. And we wanted to control the release of chemotherapy, so we had healing, and then we could deliver the drug in order to prevent recurrence. And you can see the little red marks being the residual tumor cells, with the idea that we would elute drug into the lung in that location. So what we did was we took animals, we drew primary tumors, and then we resected them. We'll see if this works. So you can see where we had a resection, and then we do the implanting of the film around there, or gave drug. And you can see that almost all of the animals had the tumor recur. If you gave, even if you gave equal amounts of the drug paclitaxel locally, you gave it systemically, you didn't give it, they all had about a 12 to 20% recurrence rate, or only 10 or 12% didn't recur. Whereas when we look at the paclitaxel loaded film, we had almost none of them came back, about 10 to 12%, and it was long term. So we would eliminate that recurrence by delivering it. And what we found when we looked at it, if we compared systemic drug at the tumor bed versus these films, there were thousands of times more drug present at the tumor bed. And we didn't get the systemic toxicity because they weren't getting it systemically delivered. So we were preventing the recurrence in that location. Lillian then went and looking at it with human tumors. And we did a similar thing where we actually grew human tumors, did the same model because we wanted to know if it was effective against the human tumors. And again, we see that even though we gave the same amount of drug in different ways, all of those tumors would eventually recur, whereas we did not see tumor recurrence in this animal model. We've now moved into large animals with Mahida, and now we have Basel and Hussein, who are all working on it. We figured out a way to scale up. How do we make large films? Mice are small, people are bigger. So we've been doing twine models of large sheets and are actually looking at testing these films where we can get different ways of releasing biphasic. You get a short burst, you get a longer burst later on, and actually looking at what's safe, do we get healing, what is our drug levels, in order to show that we can make these on a large scale with the idea of using them in sarcomas, lung cancers, a variety of different cancers. So we're working our way, but we should hopefully have those in the next year or two, I hope. The other area that we've started to look at now is this mammalian cell biomaterials, looking at a way to make implants sense and respond to physiologic or pathologic stimuli. What can we do that the implant actually starts to respond to the environment that it sees? This is Eric Ressler, who's an MD PhD in my lab, and Mark Grindstaff. So we have joint meetings, we co-mentor everyone. And so one of the things that we've come up with are, we have two things. We're looking at CAR T cells. And there is not really CAR T cells for solid tumors. And so one of the reasons is because we don't really have great ways of localizing the side effects. And so one of the things that we've just started to put out, and we'll have papers under review, is to actually look at drug-gated. So you can take a CAR T cell and make it that it'll only activate if there's a drug present, so you can release the drug locally and say, oh, only here. Or you can make it that you can shut it off by having drug present. So it allows us to start to localize where we want the CAR T cells to respond and to look at. It keeps us from having problems where we can cross-reaction with other organs if we make it only there. The second thing that we've been working on is to look at universal split CAR T cells. So the T cell can run around and it's going out, but it doesn't actually have the antigen receptor part on it. So we can go anywhere, but the only place that it can run into the antigen receptor is locally, where we can put it. You can put it in films, you can do things like that. So we can get it embedded, and it will release the antigen part of the receptor, say, no, kill tumor here. And so we're looking at ways of actually turning them on, turning them off, making them so they have to have dual gates. It's quite interesting how much you can do this. And this is all work out of another collaborator with Dr. Grindstaff, Wilson Wong. And he's really quite inventive in these things. So the ability to manipulate our response rate by using polymers as ways to give signals and to make it so we can change that is actually going to be quite an interesting part. So I encourage all of you to really find tough problems that need solving, particularly surgical problems, ones that other people won't think about, and you just have to kind of figure it out and keep going. You'll find out it doesn't seem to work the first 50 times, but there's something truth in there, and you just have to make it work. So one tough problem. We know that in stage 1, roughly 16 to 27% of stage 1 lung cancers that we think are N0 actually harbor occult nodal disease. So we need to have ways to address that because we don't know it. Where do we miss nodal disease? So preoperatively, about 18% of patients, if they are surgically upstaged on final pathology. Only about 50% of patients, if you look at the SEER database, actually have a complete lymphadenectomy, so we don't actually stage what they have, so we don't know. And postoperatively, if you take out a lymph node and you were to say, here it is, and they say it's N0 by bisecting it, if you go back and look at detailed analysis with that, even with H&E, roughly 16% of those patients will actually harbor metastatic disease. And that fits as we see recurrences with stage 1 lung cancer. That's the whole concept about we're now moving adjuvant or neoadjuvant treatment earlier or adjuvant treatment earlier in stage 1 and early stage lung cancers, at least 1Bs, because we know that there's some occult disease left behind. So we asked if we could actually find where metastatic nodal disease is lurking. This is, my daughter calls this the bad mom picture. So one of the things we started to look at was there a way to find sentinel lymph nodes and find out where the tumor draining lymph node was, and could we actually analyze those better, and could that be helpful for us to predict who needs load, who needs segments, who wedge would be acceptable to do that. And I think the newest New England Journal paper arguing about wedges versus segments, one of the critical parts that's not always talked about is those were actually all found to be N0. They really did those dissections and really proved that. Because if we don't do that, we're not actually doing our due diligence. So by driving down the airway, identifying where the lesion is, and putting dye around it, what we noticed was we got green lymph nodes, but not all lymph nodes. Only the lymph nodes were draining from that particular area. And so it's being alert and observant and saying, well, isn't that interesting? Why is that? We started to figure out ways, changing the dye, working with ways of making it so it can migrate, that we can see it in a reasonable time fashion. And so we started to look at the sentinel lymph nodes, and I was most interested in patients who couldn't do a lobectomy, because you don't need to localize it if you're going to do a lobectomy. It was in patients who had wedge resections and things like that. So we took those patients and started to look at it, and here you can see, this is the lesion we're trying to do. Yeah, and basically you just drive down, you're doing navigational bronchoscopy. You can go down, and I would put in the dye, just like people do to mark the lesion. That's nothing unique. But what we started to notice was these pathways. And some of the pathways go over the surface of the lung, and some of the pathways will go along the bronchus. And it starts to help us explain and understand skip metastases and what it looks like. And here you can see that pathway goes, and there's a green node in there. If you notice, other nodes aren't green. And so it's by looking and identifying those specific green nodes. Doesn't mean they have cancer, but it tells you they drain from this area, and you should scrutinize that. So that's what we did. So we went and looked and said, okay, on those ones where we could identify as sentinel lymph node, if the sentinel lymph node was negative, we did a complete lymphadenectomy of those and looked at all the other nodes in the specimen. And if the sentinel node was negative, all those nodes seemed to be negative, and all the patients who had a negative sentinel lymph node, we did not find any other node that had metastatic disease in it. However, if the sentinel node was positive, you could find other nodes that were positive because they have nodal disease. And in those patients, even though they'd already been staged, they'd had an EGOS, whatever, we did find microscopic metastatic disease in some of these patients that was not found. And so our argument was, well, if the lymph nodes are truly negative, the nation occurrence, we should not have nodal occurrence in that group if they're truly negative nodes. And in fact, if you look at all patients who on histology had N0, but sort them, look at them by who did we do a sentinel lymph node in and prove it was negative versus who did we not have sentinel nodes. We had a complete control group. We had the normal recurrence rate over this diagram, it's actually 10 years. We found the normal recurrence of N0 disease somewhere between 20 and 30%, depending on the era that this was done, would be about right. But in those who had a sentinel lymph node that was negative, we did not see any recurrences in any of those patients over time. So it tells me that there is occult nodal disease, and in those patients we were finding with N0 who didn't lose the sentinel node was negative, really didn't have occult nodal disease, whereas those who we could find the sentinel lymph node, we could find occult nodal disease in this over time. So the next question is, how can we target these occult nodal disease nodes that are at risk if we don't really know how to go in and find them all or to take all of them out? And so there was a study done almost 20 years ago in breast cancer where they gave chemotherapy intravenously and then took the patients every 12 hours and would go and take out the tumor and the lymph nodes and see how much drug was in the lymph nodes. And if they gave it intravenously, they had very low levels of chemotherapy in the lymph nodes, which is why I don't think it's all that effective in treating that often. And we've seen that in our chemotherapy trials not being as effective. Immunotherapy is significantly more so. But if they put the chemotherapy around the tumor, it seems that it drains to the lymph nodes, and they had much higher levels, which made us think, could we actually take nanoparticles that we could design, make them migrate, so that if we put them around the tumor, could we get them, just like the dye, go to the lymph nodes that we want to target? So we designed these nanoparticles, injected them around the tumor, and went to see if they were in the tumor-draining lymph nodes. And here you can see these little nanoparticles that are green, because they're carrying the green. We've labeled the drug green. And we made them so that they could get taken up. The tumor cells like to take them up. But they wouldn't release drug until they got into the endosome, so the pH changed. So they didn't release drug just flat going around. They had to be somewhere where they could target. And it allowed us to make it better to do that. And when we look at this, what you can see is the endosomal pH triggers it. So if you look at the blue lines, when the pH is regular pH, there's no drug release. But once it switches into the endosome, you get a slow release. We wanted to slowly release drug. We didn't want it to burst. And all the other types of nanoparticles out at that time, we just dump drug as soon as you put it in. So you can never get it to the tumor. And so there was an idea of how do we do this? And these are the types of conversations you need to have in the lab, because they don't understand what tumor is, or biology is, or the time, or what do you need. So that's the role surgeons can really do. So here we labeled the nanoparticles so that you can see that they were labeled blue, so we could see where they were, so we could use it as a way to see little tumor implants. The VLI shows us where the tumor is, so you can see they overlap pretty well. And then by having the tumor, these nanoparticles get taken up by tumors, what we found was this is your drug level, and if you just inject paclitaxel, you get a pretty fast decline over about a week that you're not having the drug stay in the tumor anymore. But if you did the nanoparticles, they had a very high level that stayed there because they're taken up inside, and then the drug would release over weeks of time, and we could get the response. So here's in a large animal, we wanted to see if we could inject at a certain site and see how far it would take them to go. And the nanoparticles are labeled green so we could track them. And what we saw was it could even go almost 40 centimeters over 24 hours, so we could certainly make it migrate the distances that we needed. It stayed in the draining lymph nodes, and you can see to the right the excised draining lymph nodes, the other lymph nodes are negative. It tells us where it's targeting. So what we wanted to know is in the animal models, did it work? Did we have efficacy? And so we looked at growing a primary tumor, putting the nanoparticle or drug around that tumor, and then evaluating what we saw in the regional nodes. These nanoparticles were labeled red. You can see how much of them are packed within the draining lymph nodes, and we could see them. What's interesting, they're in the sinusoid, which is where metastatic disease shows up. And so it delivers it where we want it. Now, if you look at on the diagram on the right, you can see the paclitaxel. If you give it systemically, there's very little in that lymph node. But if you start to look at your nanoparticles, you have a significantly more, at least 10 times more drug that is now sitting in the lymph nodes. So does it work? So what we found was we set up a model that we knew would recur, that we knew we could have lymph node metastases always show up. And when we added a single dose of these nanoparticles, we decreased it by 60%. We're now looking at models to see could we do additional doses, or are there ways to do that? Do we need to change our dose to try to figure out our kinetics of what that looks like? And we're looking at different types of nanoparticles. These were expansile ones. We're now looking at nanoparticles that can carry different things. We're looking at siRNA targets. We're looking at all sorts of different ways of traveling to get there, and what does that look like? We've also started to look at mitosis, looking at double-loaded particles where we have both the polymer and actually encapsulated the drug, and looking at how that is affecting lung metastases, which is also important. So lessons learned. One, early diagnosis and treatment of lung cancer is possible and can lead to long-term effects, and you're going to see over time, you're going to see there's a major shift in terms of what is happening in the lung cancer space. We are going to start moving early stage disease is going to start getting neoadjuvant treatment, and we as surgeons need to be part of that process, because we don't want to hand our patients over to medical oncology, because we need to determine who's resectable, who's not resectable, and to make sure that we're following those patients. The concept of using the lymphatics as a drug delivery system, or polymers to be able to do that, is actually really different. We talk about bloodstream and capillaries, but we never talk about lymphatics very well, and I think we need to start thinking about what do we see, what do you see in the OR, knowing what tumors look like, how are they behaving, where do they show up, and starting to think about genetics that are telling us why do some tumors metastasize to the liver, why do some go to the lymphatics, why do some go to the brain. We haven't really figured that out, and I think we really need to start figuring out why that is, and why do some never go anywhere. I think partnerships are really critical to your success. They're fun to do, they make you better. I think it really helps you figure out how to move your science to the next level. You really need those partnerships, because otherwise you're just doing your own ideas. And opportunities are not always obvious. You don't know who is sitting next to you in a conference. Find out. The other word of advice is remember your family. They will make you better. And as my daughters, we have a very funny sense of humor in our family. They remind me they'll be my healthcare proxy, so that I should be nice to them, because they have control, which is an interesting dynamic. But they're actually quite good kids, and it's a really important part. Your patients and your family get you through the bad days, and that's really important. Anybody can get you through the good days. So other things that I've learned is pay attention to the people that you meet at dinner. What does a polymer-chemist have to do with lung cancer? Nothing, but everything. And we've done all sorts of different things together in terms of thinking of new inventions, new ways to do things. And we're now working on all these CAR T cells, and we're working on antibody drug conjugates, and there's all the stuff that comes out of that lab that we help focus, so that it's not, things that are bad ideas to them are good ideas to us. The other is you have to recognize that research is hard, but it's really critical. It's the growth of our field. This is my dog. And you just have to realize it is hard. Every day is going to be hard in research, but you're going to make a difference. Sometimes things are unexpected surprises. These are my two daughters when they were younger. And as a parent, where you come home and you realize you haven't been home for a few days, it's always interesting to sit with your kids and hear what's going on. And one evening at dinner, the oldest daughter goes, "Mom, the neighbors across the street are really strange." And I was like, "I don't even know who the neighbors are. Like, this is a problem, right?" And I was like, my first year as an attending, and I was like, "Why?" Because I knew she'd been over there all day, and I'm like, "Why?" And she says, "The mom cooks dinner every day. And I think the dad's the doctor." And at the time, I looked at her. My husband was quite savvy, and he goes, "You have to be understanding. Other people's families are different." And he just left it at that. And she was like, "Oh, okay." If you're the smartest person in the room, you're in the wrong room. You need to find people smarter than you, because they will make your ideas better. They will keep you from wasting, practically, they keep you from wasting a lot of money and a lot of time. I would much rather have people in the room tell me that's a really bad idea and tell me why it's a bad idea, than to have the grants come back to me on the pink sheet say it's a really bad idea, because they will make my grant better. And I have to say thank you. This is truly a village. There's a number of people in my lab, as you can see here. There are a number of people in Grindstaff's lab. We co-mentor people among all their thesis defense. They've all learned about lung cancer and esophageal cancer and all sorts of things. And I do carry the Grillo Professorship with real esteem. I realize the importance of that title and what that means in changing the world in the field. Keith Willemo has been an amazing mentor to me, and the Bell's endowed a professorship for me when I was at Brigham and were understanding when I moved to MGH. And the residents, I can't say enough. They are some of my favorite people. They are good people, and they are great surgeons. So, and then the faculty that you saw there is a truly gifted group. I want to finish, and one of my kind of favorite things that grounds me. So remember, it's not about all these other things that get in your life. The purpose of life is to be useful, to be responsible, honorable, and compassionate. It will get you through your days, your patients, and your family. And it is above all that what you really want is to matter, to count, and to stand for something, and to have made a difference. And I cannot think of a better place to do that than Cardiothoracic Surgery. It was a gift that I didn't think about that as an opportunity, and I just did it. You should do